All right, so just to reiterate the introduction, our team attended the Citywide ID conference last week and will be presenting on the case involving polymer sloughing from a TAVR catheter used to deploy a transaortic valve replacement in a patient. Patient presented with granulomatous formation in tissues located all over her body. And this is obviously a pretty severe complication that we wanted to discuss further. I'm tasked with the health systems question, and the question I'm interested in asking is what are the most common complications and associated costs following the transcatheter aortic valve replacement? So just a quick overview of what we're talking about here. TAVR is a recently developed, less invasive surgical procedure that entails threading a small catheter through the femoral artery access to locate the aortic valve, with a synthetic valve being deployed within the existing diseased valve to restore valve competency. The volume of TAVR procedures has slowly increased over the past 10 years or so, with almost 73,000 procedures being performed in 2019. So really representing sort of the most common replacement method of replacement of for diseased aortic valves, and outcomes have continued to improve over that time from about 2011 to 2019, with in-hospital mortality falling from around 5.5% to 1.5%, and with 30-day mortality decreasing somewhat similarly from 7.2 to 2.5%. So our spiral here is going to address the most common cause of diseased aortic valve, which is aortic stenosis. I think we all know this fairly well. It's the most common type of left ventricular outflow obstruction, and it's the most common indication for aortic valve replacement. This often occurs in older patients due to calcification of valve leaflets, and they commonly will present in clinic with dyspnea and reduced exercise intolerance, dizziness, syncope, and chest pain. On physical exam, clinical signs we'll be looking for are low volume and slow rising carotid pulse. Look when you investigate in the carotids, a loud mid to late peak systolic murmur in the right intercostal space, and a single second heart sound. And then this little diagram here just outlines sort of different criteria for the traditional marker of severe stenosis, and then novel markers for severe systemic stenosis. The paper that I found was titled "The Cost of Peri-Procedural Complications in Patients Treated with Transcatheter Aortic Valve Replacement," and this study was relatively recent. The study involved a study population of 406 patients with severe symptomatic aortic stenosis who were randomized and received TAVR as part of the PARTNER clinical trial. Costs were assessed from the perspective of the U.S. healthcare system using per item costs, procedure costs, and physician and staff fees. And the statistical analysis consisted of controlling for confounding by considering factors that were shown to be either highly associated with both the occurrence of the complication or with a higher burden of costs for patients that didn't experience complications. That's kind of a standard univariate analysis of looking at potential different factors that were available that could potentially confound the relationship between the rate of occurrence and the overall cost of complication. And they further assessed the cohort using a multivariate logistic regression, controlling for factors they identified in the univariate analysis, as well as some baseline controlling factors, including sex and age, and some interaction terms to look at effect modification. So results of the paper showed that the mean cost of the index of hospitalization for all patients was almost $80,000, $79,619. Patients who experienced any complication had a substantially higher cost during their hospitalization, and the multivariate model, adjusting for demographics, the clinical characteristics, and these other factors that were identified in univariate investigation, showed 7 complications that were really associated with high increased costs, and these were death, which obviously is very costly for the hospital system, major bleeding, renal failure, and then having to repeat TAVR because you have a failed replacement of the valve. And the most common was the major vascular complication, and overlapping with the most expensive. So really it's major bleeds that are one of the major issues here to consider. Notably, our patient case was not present in the most frequently observed complications post-TAVR. I think with this case was just so rare, and just the incidence of polymerization of plastics from a failed catheter is really, really rare. So overall, his conclusions are TAVR is a reasonably cost-effective procedure for individuals who are not candidates for surgical aortic valve replacement and for other high-risk patients that have aortic stenosis. So any strategy that's going to be able to reduce the frequency of complication post-TAVR is likely to be an important approach for overall controlling of costs, with the complications accounting for $12,475 per patient in additional hospital costs. Bleeding, death, arrhythmia, and post-procedural renal failure were the greatest, contribute to the greatest increase in overall healthcare costs and were recognized as the most common complications post-TAVR in this paper. Likelihood of complications is likely to decrease with greater operator proficiency and institutional experience. This is something that basically explains the decrease in mortality over the past 10 years that TAVRs have been used. It basically comes down to the institution being better at managing teams that conduct TAVRs and also just with better proficiency in the interventionalist or surgeon that's completing the procedure. Thanks so much for listening.